Hi, welcome to Detours Understanding Acquired Brain Injury. And with us, you recognize Jennifer. She's spoken with us before. One of our more popular topics is dealing with neuropsychiatric problems, brain injury, and mental illness, because it's probably the most disabling of the symptoms, whether mild or severe acquired brain injury, whatever it may be. Um, this type of brain injury has a profound impact on this domain of symptoms. And so we talk a lot about it because it tends to be something that when you first talk to somebody with brain injury, you don't notice initially, but it really is the thing that affects the ability to work, socialize, interact. And a lot of people who already have brain or who have mental health challenges, who have any kind of mental illness, oftentimes are more vulnerable to acquired brain injury. So I will hand this over to Jennifer to get started.
Sure. So my mental health issues are from birth. I was diagnosed with ADHD when I was 8, in 1982 and put on Ritalin. And then I was diagnosed with schizophrenia at 17 after my first attempt. Um, and then I got reassessed for ADHD when I was 18. And then I got diagnosed with epilepsy. I've had epilepsy as well. Um, and then my brain injury happened because I had a grand mal seizure and I fell and hit the back of my head really hard and had brain bleeds, and I was unconscious for a long time and whatnot. But after my brain injury, actually a few years before my brain injury, I'd had a relapse of my symptoms and I was in and out of the hospital a lot. And then I had my brain injury happen and I continued to be in and out of the hospital a lot. And it wasn't until about a year ago in March that I had my last hospitalization, and I've been out since then.
Okay. Um, Speaking as there are different patterns that people follow. There are those who have strong genetic history of whether it's schizophrenia, manic depressive disorder, uh, clinical depression, many of these different, these more chronic mental illnesses, and then they sustain a brain injury. And most people who follow that path have a strong genetic predisposition for whether it's schizophrenia, depression, anxiety disorders, whatever and they have their diagnoses, typical age, and they have other disorders. And then the brain injury, the traumatic brain injury, some studies show that the traumatic brain injury seems to come as a result of symptoms they have associated with the mental illness. So maybe because they have problems with attention, focus, which does come along with, I know you would know this, along with schizophrenia or with depression or anxiety. And so they may not be as quick on their feet or whatever. They may trip and fall, or they may have an accident or something along those lines. And so there's that side of things. So then that brain injury just makes things worse, magnifies their symptoms. And if you're a child that has, any of these kind of disorders, you have a childhood brain injury, I mean, then you've got all the neurocognitive and learning disorders that come with it on top of that, or may even end up with then a diagnosis of an intellectual disability or things. There's that side. And then the other side is somebody who has no mental health diagnoses, they sustain a brain injury, and then they show medical mimics of depression, anxiety, or more what it's not
Mhm.
schizophrenia, but you may end up with, and I even have a video, paranoid delusions, hallucinations, usually auditory, but sometimes visual. And this is something to understand. If you're seeing a lot of visions and things, after an organic disorder, it may be suggestive of a brain tumor or of a more severe kind of a brain infection, and in some cases, it's TBI, but usually it's something that is progressive, Lewy body dementia, something like that, especially if it's later onset. And so that catches our attention if you say you're seeing things as opposed to hearing things. Now, obviously, with schizophrenia, seeing things is not as unusual. That does happen in some cases, although more hallucinations are auditory. In some cases, TBI can induce hearing voices, things like that, but the visual hallucinations are more a sign of an organic problem. So in those cases, TBI mainly, but in some others, you definitely have not the classic, it's more of a paranoid type delusions from damage to certain areas of the brain that regulate dopamine release. And this takes time. It won't be immediate. It could be up to 2 or 3 years after your brain injury. You start to become more paranoid because it takes time for that atrophy of those control areas in the temporal lobes. And you could see that on a brain scan. But that pattern is more fixed in people with an acquired, like I have clinical depression, major depressive disorder with due to a medical disorder, which is traumatic brain injury. And I have enhanced anxiety. I had anxiety disorder before, but it's certainly much worse now, including panic and other things. So, I follow that second pattern, which is brain injury first, symptoms, mental health symptoms later. But a lot
Mhm.
of people have primary mental illness first, then traumatic brain injury, which just adds to the complexities. And so, it's like, so both are, and then you get into that chicken or egg thing, which came first, especially if you don't receive medical care. Like,
Mhm.
is it a problem caused by a brain injury, or is it a brain injury caused by something else that came first? And we're discovering other diseases of the body can cause mental illnesses and can cause acquired brain injury, so it's like, um, we've spoken about those, but certain endocrine diseases can cause that. Inflammatory diseases can cause, I mean, anti-NMDA receptor encephalitis. So an autoimmune disorder causing things that look like a psychosis. But if you treat the strep, staph, or tumor, then the psychosis, the hallucinations, again, visual hallucinations suggesting an organic process. Um, mm, so it's really complicated problem, and filtering out. I mean, that's what the whole discipline of neuropsychiatry and neuropsychology are about, figuring out brain, behavior, and usually the two are heavily woven together. And usually it's
Mhm.
neurology, it's genetics, it's mechanical stressors.
Yeah, I think I have a family history, a very rich family history of psychotic disorders
Hmm.
and ADHD.
Right.
So, but I will say, excuse me, after my traumatic brain injury, and I experienced neurofatigue,
Yeah. Mhm.
and that exacerbated. So, my schizophrenia is primarily not hallucinations,
Right.
primarily delusions.
Okay. Yeah.
And I don't have persecutory delusions usually. I have delusions of reference and delusions of thought. And
The atypical cluster, which again is you see also in brain injury. Those delusions, it's like you do typically get the persecutory type with head injuries, but your neurofatigue and the adynamia and those other symptoms you describe, you do also see in brain injury. But you're right, the persecutory are more head injury, but everything else you described, I was like, that could have been made worse by.
well, yeah, and it was made worse. I think the neurofatigue wasn't made worse by the mental illness, but the neurofatigue made the symptoms of my mental illness worse for a while. For probably like 3 years, I would say. Uh, it was the neurofatigue made me even more in my head.
Mhm.
And as someone with a psychotic disorder, being in my head all the time is the worst thing for me.
Right.
So when I was on the sofa for 2.5 years after my traumatic brain injury, that just gave my thoughts a way to fester.
Yeah, oh, yeah. And then you had that adynamia. We talked about the salience network, which helps identify things that you should pay attention to or not. And that is often damage and head injury. So a lot of people with brain injury, and you see this with mental illness as well, it's that system that allows you to switch to external focus to solve a problem in the environment. And it switches you then back to inward looking memories, thoughts, things like that. That system is often damaged in brain injury. It's that frontal circuit that allows you to move back and forth. It's like your gear shift, and that is often screwed up. And so, if that gets damaged in traumatic brain injury, you have a lot of hardship in moving between being internally focused on, and talk about making a any kind of thought disorder or depression. This also magnifies depression in people with traumatic brain injury. Um, they can't get out of looking inside to looking outside. Hey, you got to clean up, you got to feed the kid, you got to, do these things. These are external focus. And
Mhm.
if the salience network does not shift you from taking care of inward to out, if that's busted, you're stuck. And this is why we use like ADD, ADHD medicine to treat that, things like that. Kids with ADD, ADHD have problems with that system. You already had problems with your system because not only the schizophrenia, but the ADD, ADHD symptoms gave you trouble with that to begin with. And then you damage it further, and it's really hard. So you need certain medications to help you regulate that system. So you got a double whammy. And this is what I was talking about, you being that first type of person who already has neuropsychiatric problems, problems with the neurological systems that control that to begin with. And then you add the burden of neurotrauma. And so it just complicates. And so this is where we're left trying to resolve that challenge, and find things that work. There are things you can do, but mm, what I'm hoping is some of the things we're seeing, like with deep brain stimulation and stuff like that, will definitely help more. But these things are still in the lab, so they're still doing experiments. So maybe another 15, 20 years before we see them in regular use.
Well, interestingly enough, my psychiatrist, right after I had it, said, and I did feel this, like my mental health did not get worse right away. It
Mhm,
actually improved from the seizures.
mhm,
And I had ECT suggested to me a couple of years after the brain injury,
mhm,
um, to bring me out of psychosis, which I ended up not doing it at the time. Um, but because the seizures precipitated the brain injury, it
mhm.
actually gave me a bit of a boost in my mental health initially.
That's where the idea of ECT came from, was looking at seizure patients who seemed to do better after they had seizures and seemed to be in a better mood, better mental state. And they were like, hey, since this helps, naturally, why not induce a seizure in patients? And so, ironically, yes, with patients who have deep clinical depression or other mental like disorders who have seizures, yes, they can shortly after having a seizure do feel better because it releases a seizures and like a severe electrical propagation across the brain triggers a release of all the major neurotransmitters, including serotonin, dopamine, norepinephrine, and it can lift the moods, kind of like giving you a pill to elevate your serotonin, norepinephrine levels. The problem is it releases all of them all at once. And over time, you use up what you've released, and then you're back in, you got to resynthesize. So there definitely are, effects, but that's why.
Yeah, I didn't do mine for mood. I did it for psychosis, but
Right. Well, that'll help too, because you release the other
Mhm.
inhibitory neurotransmitter, like everything at once.
Mhm.
That's why it breaks a psychotic episode too. But, it's like, and it's like hitting, trying to solve the a bad street in your town by dropping an atom bomb on the city. Sure, it'll clean up the crime in that one street, but it's a bit overkill, you know.
Yeah, I don't know. I was thinking of doing it because I had the psychosis that just wouldn't quit. I had it for like over a year.
Mhm.
I was in the same episode, so
Well, some people meds don't work. There are those cases that are truly medication refractory, and that's the really the last resort. And for those cases, I've seen it work. And there are
yeah,
people
well,
who
I've been
know that.
refractory before, and actually a third of all schizophrenics don't respond to medication at all.
And so in those cases, sure, there's definitely a place for it. I just am like, that definitely is the last resort. And I'm hoping some of the new meds, the variants on ketamine and things like that help. I don't know. For now, the ECT has a place, but it's like it's a very narrow application. But yeah, for those who nothing else works, you got to do what you have, what you're, if that's what's the tool in your toolbox, you got to use it if nothing else is working.
Yeah,
I mean, think about what we do for people who are in a bad cardiac rhythm and they're not, we shock them. We shock them to disrupt the aberrant rhythm. It's extreme, but it works. Not always, but it works. So, it's like you're in a pretty bad place if we're going to defibrillate you. But, if it's done right, if we're doing everything else right, okay, so be it. And that's how I feel about like ECT. It's like if nothing else is working, that's what you got to do. It's just having the wisdom to know when things are necessary. That's why med school is hard. That's why nursing school is hard. That's why, because you got to have the wisdom to know when to do these things.
yeah,
And it requires a patient who knows too. A lot of our patients who received that treatment will come and say, I need this now. They knew it and they asked. You got to know yourself. I mean, as the saying goes, a 20-minute search on Google doesn't make you the equivalent of a doctor, but you know, 20 years living with a disease or a disorder isn't the same as a 1 hour lecture in a med school, you know.
yeah,
So you are the expert on your disorder. And that's why it takes some assertion with a physician, especially with things like brain injury or serious mental illnesses. You gotta be able to get in there and say, hey, huh, you know,
yeah. I've been very fortunate to have good psychiatrists and good neuropsychs, and I have a great neurologist.
yeah, that makes a difference.
So
it's worth
I've had
taking
good
some to look.
occupational therapists and cognitive remediation therapists and
Mm. Yeah, I've been fortunate too. I've had people who know, and I'm fortunate because I do know myself and because I do this, and it's like working hand in hand is so important. But so many people that I know have not had that fortune. And so, I mean, that's why we all do what we do. That is what teaching it all is about, to help. And that's why something like this is important to, like address the fact that how things interact and what symptoms are and how things go, and things to be aware of.
yeah.
All right, I do want to say, if you have any questions you wish to direct towards Jennifer, anything she can help you with as far as mental illness, brain injury, that kind of thing, please feel free to ask her. Put it in the comment section below. If you have any questions on the neuroscience side, please direct them towards me or anyone else who talks here at Friends Brain Injury. Any questions for us, please um, don't don't hesitate to add comment below. We get a lot of good comments and a lot of insightful stuff, and so I want to thank you for participating. Please click like, subscribe. Don't forget that bell icon. Visit our website. We have a good website at Friends Brain Injury, and we also have a presence on Facebook. Again, friends with
We're on Instagram too.
yes, and Instagram. Don't forget to check out Instagram. Sorry, don't want to forget that. Um, and so there's a lot of good resources out there if you look. And of course, we do have videos, and we have groups that meet Saturday at 1 through Facebook. There's the link there. And we also have a Monday evening group at 8 Eastern. So please feel free, and we hope to see you again really soon. And we'll talk to you later. Bye.